There we go. Welcome, everyone. Good morning. Today, we are going to be going through chapters 5, 6, and 7 of our BHA provider rules. We will be spending the lunch hour here. Appreciate it, spending it with you all today. So we will go ahead and get started. Next slide. We start all of our meetings with our Behavioral Health Administration, or BHA values, which are truth, equity, collaboration, community-informed practice, and generational impact. These are all values that we take into consideration in the work we do every day, and we like to mention them at the beginning of all of our stakeholder meetings, so you all know what those top priorities and values are as well. A few housekeeping items. So as you see, the video is being recorded and will be posted on the BHA website and on our YouTube channel. BHA staff will have access to the chat and transcript to ensure your comments are captured, and we encourage you to share whatever you are comfortable with in this venue. Throughout this Zoom town hall, you can use the chat function to send any questions or comments. We also encourage you to raise your virtual hand, and we're happy to call on you to unmute and ask your question or provide your feedback. We also have an email inbox that you can see here, and we will also be dropping that throughout the presentation today, so you have access to that. That is an email inbox that is monitored daily, and we are happy to receive any feedback or questions through that inbox. We also have a Google form and survey response that you are welcome to use to send us input, and we appreciate you all and your participation today. We are also joined by American Sign Language, or ASL, interpreters. We have 2 interpreters that will alternate throughout this session. If you want to view the interpreters, you will select pin. You will pin these boxes to your main screen. Those names are ASL interpreter Adrian and ASL interpreter Cynthia. You will select gallery view from the upper right-hand corner of your screen. Click on the ASL interpreter screen and select more, or the 3 dots. Pin the video, and then repeat the process for the second interpreter. And we'd like to send a special thanks to Adrian and Cynthia for their assistance today. Next slide. So in today's town hall, we will be reviewing chapters 5, 6, and 7 of our proposed rules. These numbers have changed since this fall, if you engaged with us this past fall and winter. Chapter 5 is outreach, education, and engagement. Chapter 6 is recovery support services rendered by peer support professionals. And Chapter 7 is outpatient and high intensity outpatient services. Now, we have a number of different stakeholder opportunities going on throughout May and June. This town hall is more of a presentation and content heavy event than some of the others. Some of the others are more of a listening session, and this one's really more of walking through the rules to make those a little more digestible. You can visit our website for upcoming events. And we also are coming out with a new way to stay informed, a quality and standards newsletter. We've received feedback that that individuals interested in these rules would like some more communication about these events, about when updated resources are available on the website. And so we encourage you, if you are one of those people who is really interested in keeping up with the latest on the rule update, encourage you to sign up for this newsletter that we will be starting to distribute to keep you up to date. I'd also like to pause now and introduce our BHA staff that will be presenting today. I can start with myself. My name is Victoria Lasky. My pronouns are she, her, and I am the Safety Net Associate Director at the Behavioral Health Administration in our Quality and Standards Division. I will hand it over to Tom.
Is this your way of telling me that I'm presenting today, Victoria?
You are our special guest, Tom.
I like that option much better. Thank you very much, Victoria. Good morning, everybody. Thank you for joining us for chapters 5, 6, and 7 with the BHA. My name is Tom Miller. He, him, his are my pronouns. I am the Division Director for the Quality and Standards Division, and proud to be a member of this team that's doing outstanding rule revision work. With that, I will hand it over to Mel.
Thank you, Tom. Hi, everybody. Welcome. We're so excited to see all of you here. My name is Mel Tyler, she, her pronouns, and I will be talking to you today about Chapter 5 and parts of Chapter 7. And I will hand it over to Mariana.
Sorry, my little bar disappeared there for a second. I had to find my unmute button. Good morning, everybody. My name is Mariana Sears. My pronouns are she, her. I am one of the safety net licensing managers that is helping with the rule redraft, and I will be presenting a little bit today around some movement that we made with Chapter 7, in particular, incorporation of withdrawal management services into our outpatient level of care. And I believe our last safety net team member that is on the call today is Olivia Zern. If you can come off mute, Olivia, and introduce yourself, that'd be great.
Good morning, everyone. Thanks for being here. Olivia Zern, she, her pronouns. As Mariana said, I'm a safety net licensing manager. I will not be presenting today, just taking notes, but glad you're all here.
Great, thank you so much. And looks like we have excellent turnout today. Really appreciate all of you being here to learn more about these chapters. And again, we will be pausing throughout the presentation to take any questions or comments. So just know that if you drop a question in the chat, we will be holding those until we are stopping to do questions. So appreciate your engagement. We've got a great show for you today. All right. I'm going to be doing a little bit of a background on the rule update, just in case this may be your first event. Won't be going into too much detail, but just want to really set the stage for the 3 chapters we are presenting today. Next slide. So legislation back in 2019 created this new license type, the Behavioral Health Entity License. Behavioral health services in Colorado have historically had to have different licenses, designations, and approvals across multiple state departments, including the Department of Public Health and Environment and the Department of Human Services. So this was created to bring substance use disorder services and mental health services together under one license type. Phase 1 of the BHE started July 1st of 2022, when mental health providers were required to obtain a BHE license from the health department. We will be moving into Phase 2 of the BHE license starting January 1st of 2024. This is when the BHA receives authority for this license type, and it's also when substance use disorder providers are included in this license type as well. And by January 1st of 2025, all BHEs will be licensed by the BHA. So whether that's transitioning a license from the health department to us or starting a new license with us, the BHA will be the only state agency in the BHE business by January of 2025. An important concept to mention today is this license type as a base license with endorsements. So today we will be reviewing 3 endorsement chapters. This is our first town hall going through endorsement chapters, and those are specific to different types of services or populations that a behavioral health entity might serve. So agencies that hold a BHE license choose which services or endorsements they offer, and they apply for those endorsements to be added to their license. CDPHE has called this a cafeteria style license. Each provider must have at least one level of service endorsement because that base license is really just a general requirements to operate the business. And then the service requirements are added on depending on what the provider wants to do. So specific chapters of rule contain requirements for each endorsement. And some endorsements contain sub-endorsements. For example, our residential services chapter includes various American Society of Addiction Medicine levels of care, or ASAM levels. Next slide, please. And this is just a visual representation of that cafeteria style model. So we have the base license and then added endorsements. The service type endorsements are outpatient and high intensity outpatient, residential, emergency/crisis and recovery supports. We will be reviewing 2 of those today, outpatient and recovery supports. Then we have those population-specific endorsements, for example, for children and families, for criminal justice involved individuals, and a couple of others. And then also these endorsements applicable to comprehensive community behavioral health safety net providers, which is a specific provider type. We talked a little bit more about that in last week's town hall in chapter 3 about that approval process. And this chapter 5, outpatient or outreach, education, and engagement that we will be reviewing today is only applicable to those comprehensive community behavioral health safety net providers. Next slide. With that, I will hand it over to Mel to start walking us through chapter 5.
Thanks so much, Victoria. Again, hello, everybody. I want to start off by saying how appreciative I am, and the rest of the team I feel comfortable speaking for, and how appreciative we are of the feedback that we have received since we started this whole process back in stakeholdering back in December of last year. And I truly, truly believe that particularly chapter 5 and chapter 7 are better products now than what we first introduced back in December, because of the engagement that we've received and the collaboration from our stakeholdering partners. So thank you so much. I just wanted to make sure I said that before we started talking about the chapter itself. Speaking of chapter 5, outreach, education, and engagement services. And again, as Victoria said, this specifically applies to those comprehensive community behavioral health providers providing this service. Next slide, please. So what does this mean for folks in the community who may be receiving these services? Well, approved comprehensive community behavioral health providers are required to look at the behavioral health treatment needs of your community and find creative ways to fill those gaps. This includes holding events that allow your community to learn about the treatment that is available to you. These providers also have to report back to the state on your community needs and how they are tailoring their services to address them in order to increase community-informed services in Colorado. Next slide, please. What are outreach, education, and engagement services? Well, again, these are required specifically for those comprehensive community behavioral health providers. And we have defined this as focused efforts by an agency that has identified priority populations and service needs in the agency's community that require higher levels of active engagement to produce those positive behavioral health outcomes, including a reduction in behavioral health disparities in access to and engagement in care. Now, I want to park here for just a quick second because I know in some meetings prior, we've had some confusion around the term priority population. And so when the BHA is referring to priority population in terms of the safety net, this is specifically speaking to that definition from Bill 1278, which the statutory reference is 27, oh, I've got it right here, 2750-101 17, both A and B. So this is not connected to the block grant or connected to HCPF and their definitions of priority populations, but again, specifically to that statutory call out for the BHA to serve this priority population that was deemed needing this extra services of the safety net by the state of Colorado. Next slide, please. So one of the things that is required of these comprehensive community safety net providers is to complete a community assessment. Now, this assessment must look at community behavioral health treatment needs within the geographical area that the agency serves. And then we left that broad, understanding that each agency's geographical area can look very different. Now, this assessment may be one that was used and was completed for another government entity or through a third party. It also could be an assessment that is by the BHA or by a BHA designee. Now, if you're using an assessment that was previously completed by one of these parties, that assessment must not be older than 3 years. If you're creating your own assessment, then that assessment must include, but is not limited to, engage and interview community stakeholders that address those social determinants of health, define the community the agency serves by gathering information, including demographics of the community, social determinants of health, and priority population data, and assess unmet needs in behavioral health treatment levels of care within that community. Agencies must also reassess at least once every 3 years. Next slide, please. These agencies also must develop a strategic plan. So that strategic plan is to, sorry, I just got some feedback, making sure everybody can hear me still okay? Okay, just making sure. The plan must include that identified priority populations and treatment needs from that assessment. Plans for services to meet the priority population must include, but again, is not limited to, how outreach, education, and engagement services will support efforts towards screening, early intervention, and treatment of those priority populations. Also, off-site events and intentional engagement with priority populations. Now, this can be broad community events. We want these agencies to include community partners that address those social determinants of health, bring in local law enforcement, local public health departments, whomever you feel helps your community in terms of increasing behavioral health access. And then how planned outreach, education, and engagement services can improve behavioral health outcomes of that community, and how data will be gathered to measure those outcomes. Next slide, please. Then we want y'all to engage, get out there, get involved, have fun. Gather and interpret that data from those events received from outreach, education, and engagement service outcomes, and then provide a data outcomes report to the BHA at a time of licensure renewal or upon request by the BHA. And this includes an updated strategic plan for the following licensure year, which includes a summary of those events for outreach, education, and engagement efforts of the previous year and goals that were developed from those efforts. All right, that is an overview of Chapter 5. What questions do y'all have? Okay.
I have a quick question, Mel. This is Callan Ender with Building Hope in Summit County. Do we have to, as a entity providing those services potentially, do you need to provide the strategic plan to the BHA during the application, or what is the requirements around that?
That's an excellent question. That has not been fully fleshed out as far as when that initial strategic plan needs to be included, because that assessment process needs to happen before the strategic plan is developed. I saw Tom nodding his head. So I will call on Tom here really quick and see if he has any further thoughts about this.
My nodding was that I think that's an excellent question. And I agree that I'm not sure we have fully fleshed out the process for completing that at the time of application. I can see, if I put myself in the shoes of the provider, that may be something that the provider needs to do after starting services. So I wonder whether that would put the applicant in an awkward position. I would love your thoughts about that. And Frank, I wonder if you have some thoughts about that as well.
No, Tom, I had a different question. So if there's more discussion on that one, I can hold off in a second.
Yeah, Frank, before we move on, I wonder if we could go back and to the person that asked the question. I think you dropped off my screen, so I don't see you anymore. Is there a concern about timing? There you are.
Hi. I don't think there's a concern about timing, just curious on what we'll need to have ready for the application and if we'll need to think about that strategic plan, but it does make sense if we're having to do an assessment to do the assessment first before the strategic plan. So just outlining the services that are being provided would be probably better, and then developing the strategic plan after the assessment.
Right. That's kind of how I was thinking about it. And at a previous stakeholder meeting, I was asked the question about having the assessment at the time of application. And I did say yes, that we would want to see that and vet that as a part of determining fitness for the facility. I could see that the strategic plan may be something that comes later depending on the group of people that the provider is serving. But to the safety net team, let's note that for additional conversation, and we will provide clarification.
Thank you.
Yeah, thank you for asking. Frank, over to you, I think.
Thanks, Tom. First confession, I have not dug into this version, as it did the previous. So want to ask if there were any clarifications made to the role or the role or communication with the BHAs in relation to the community needs assessment. Thank you.
Appreciate that question, Frank. Thank you so much. That was something that did come up in previous stakeholdering, and with the passage of the BHA implementation bill, that has pushed out that BASO timeline a full another year, from July 1st of 2024 to July 1st of 2025. So for good reason, because we wanted to make sure that we took some more time in developing the BASO and make sure that we're addressing all the needs of the state. However, these rules need to get up and running by January 1st. So we need to make sure that we have these outreach, education, and engagement services started for those comprehensive service providers instead of waiting a whole, another year and a half, 2 years. So for that community assessment piece, though, we did broaden the language that it can be from a third party, it can be from the BHA, from a BHA designee, from another community service partner. It really is just making sure that those minimum requirements that I mentioned earlier are included in that assessment, and that the assessment is not older than 3 years.
But in terms of the flow of the report and the strategic plan, that is provider to BHA. BASOs at some point in the future may have access through that process, but there's no requirement for comprehensive providers to deliver that to the BASOs themselves.
Correct. We do not have any language related to the BASO at this time, since we're still trying to figure out what the BASO is going to be. So,
thank you.
Sure.
We have a couple of similar questions in the chat. One asks, what expertise and resources will BHA provide to support completion of community assessments? And does the BHA expect to approve plans? I think I'll just say something quickly, and then Mel, if you want to add anything. I think these rules now state that assessment, it's not that the provider has to complete the assessment. If the BHA is doing that work, or it says, or its designee, I think in our mind, we're thinking that would be the BOSSOs are doing that type of work, that can be used for that community assessment piece. So that was I think one of the big changes that happened in this chapter from then until now is allowing for more, in order to reduce that duplicating that work. In the BHA, if that's something that's moved forward, again, as per Mel's point, we're still figuring out what that BOSSO structure and functions look like, but we would be happy to use that as the assessment for this purpose. Is there anything else you'd add there, Mel?
Nope, I would not add anything to what you said. It was great.
Mm-hmm.
I guess the only question that raises is on the payment side, who bears the cost when it's a designee versus a provider, just because those requirements are baked in to the definition, assume that the payment model pays for the things that are required there. So I don't know if there's any thinking about when you're using an outside assessment or a designee, how that factors in there. And maybe that's premature for another day when we have more details on the payment model for the different provider types.
Frank, I would just say I think that's another right question, if you will. And not that it's premature, I think it's important for us to consider that when we're developing various BOSSO models, to determine how payment for those kinds of assessments may or may not factor in. I don't have an answer right now. I don't know if Mel or Victoria, you've done more or additional thinking on that. So I think that I'm seeing two shakings of head. But Victoria, you just came off mute.
Yeah, I just wanted to ask a follow-up clarifying question, Frank, to make sure I understand the question. Is it that whether payment is different based on if the provider does the assessment themselves versus uses an existing assessment? Is that the question?
Yeah, essentially. I mean, you sort of anticipate that the payment model for the different types of providers is based on what they're statutorily and regulatorily required to deliver. So just thinking about the different scenarios on, whether they're conducting the assessment in strategic plan or they're using another community process or going through designees.
Sure. Understood. Thanks for helping me understand that better. And yeah, I think per Tom's point, something we're definitely considering as we're figuring out what this payment model looks like. I see Heather, similar question. Many communities have already developed a community assessment, and we are already working with them to meet the needs. This would be duplicative work. Are we able to utilize the processes already in place by developing our strategic plan from the current assessment? My understanding of that would be yes. What are your thoughts, Mel?
Yes, correct. Again, if it is an assessment that meets the minimum requirements that are listed in the chapter and informs that strategic plan for the agency, absolutely use it. I don't want y'all to have to reinvent the wheel. If you got something that's working in your community, let's use it. Yeah, we don't want to increase provider burden by this. We're just wanting to make sure that we are filling those gaps and figuring out what they are within your community. And Heather, I saw you turn your camera on. Did you want to add anything at all?
No, that's very helpful. I was just giving you my nod and smile for thank you. I appreciate it.
Thank you.
All right, well, with that, I think we can move on to chapter 6, doing a bit of a time check. We're half an hour in and we've got a couple more chapters to go. Chapter 7 being the most complex and longest, I think. But I will go ahead and dive into chapter 6, which is behavioral health recovery supports endorsement. So this, one thing I want to be very clear about, because this is something that understandably gets confused a lot. This is separate and distinct from the Recovery Supports Services Organization, or RSSO license. That is a separate license type for peer support professional led and run agencies providing recovery support services. And that license allows them to bill Medicaid for those services. This chapter is specifically an endorsement for behavioral health entities or safety net providers that are providing recovery supports through peer support professionals. So you can see who does this apply to. That includes licensed agency, specifically a BHA licensed agency providing recovery support services. Comprehensive community behavioral health providers are required to have this endorsement. So this is one that is required. And just as a note, comprehensive community behavioral health providers can provide the service themselves or contract out. And then we have essential behavioral health safety net providers approved to provide the service. Next slide. Person-centered summary. So for all of these chapters, we have this person-centered summary. It can be helpful to have a connection with someone who has been through what you're going through. Peer support professionals who have their own experience with a mental health or substance use disorder can help you on your recovery journey. And they may help you through recovery coaching, peer support group, helping you find a job, connecting you to other services you need, among many other things. So this chapter describes what standards agencies have to follow if they employ peer support professionals. One thing that I want to be clear about here too is that the responsibility of this chapter falls to the agency. This is not an individual license for peer support professionals. This is a facility level endorsement. Next slide, please. So in this chapter, we have the list of service provisions. We have the list of services provided by peer support professionals in settings they may be provided in. This list in particular came from some legislation that came back in 2021, House Bill 21-1021, that established RSSO. It very nicely listed out the many functions that peer support professionals may serve. And so we use that here. And also importantly in this piece, and this was a piece that we did a lot of stakeholder engagement about in our first round, about peer support professionals not providing services that compromise the dynamic of a peer-to-peer relationship or that are outside the scope of providing recovery-focused services. So this is something that we hear about fairly often, that peer support professionals are asked to perform tasks that are outside of their role as a peer support professional, specifically things that may create a power imbalance, such as performing clinical or diagnostic assessments and drug testing. Those were the two specific examples that we added to the rule based on stakeholder feedback. So that is specifically included here. Previously, when we've had this issue come up, our regulations do not speak to peer support professionals. And so at this point in time, we cannot do anything to help enforce and shore up that scope. And so adding this to the rules really ensures that peer support professionals are protected as that very unique and valuable service of offering a peer-to-peer relationship. And also in here, there's the requirement that agencies submit job descriptions of peer support professionals, again, to just take a look at that appropriate scope. Next slide, please. We also have a section on staff qualifications and training. So for peer support professionals, there are kind of two paths here. There is peer support professionals either certified, and the next slide will go into a little more detail about that, or have documented training in core competencies for peer workers from our federal partners, SAMHSA. So that was also included in that legislation I mentioned earlier, that specific call out for those core competencies. I won't read them all out, but you'll see on this slide, that's a list of all of those core competencies for peer workers. And then if the peer is choosing to be certified, then they would need to be in good standing with their certifying body. Next slide. So if a peer is choosing to be certified, the certification shall consist of at least 60 hours of training, at least 200 hours of experience as a peer support professional, and passing a certification exam. This set of requirements encompasses both the NADAC NCPRSS certification, which is a national level certification, as well as our local Colorado CPFS certification through COPA. So knowing that we have peer support professionals in Colorado that have chosen both of those different paths, wanted to make sure that both of those were accounted for in the regulations. Under supervision, this is one that also has undergone some feedback and revision. So ongoing supervision by either a licensed mental health professional or an experienced peer support professional. We wanted to allow this supervision structure to be flexible based on, we know that peer support services are provided in a variety of settings and encompass a variety of services where it may be more appropriate for a supervisor to be a licensed mental health professional or an experienced peer support professional. I want to note that this is distinct from any healthcare policy and financing Medicaid billing requirements. There may be some specific requirements on their end to bill, but on our end wanted to make sure that this licensing piece is flexible and broad to meet the needs of unique agencies. Supervisors of peer support professionals shall demonstrate having training in the provision of peer support services, supervision of peer support professionals, and the role of peer support professionals. This was another requirement that was borrowed from that RSSO statute. Very important that those supervising peer support professionals know what that scope is and that role is. And then also included here, based on stakeholder feedback, was that supervision may include co-reflective supervision strategies that emphasize mutual learning. Documentation requirements, we kept these fairly broad, again, trying to account for a variety of types of agencies. The expectation here would be that if you are an agency that is billing Medicaid for these services, that the claim that the documentation required for reimbursement would be sufficient for the purposes of licensing. So behavioral health providers shall maintain records, and again, that flexibility to account for different provider types. So if you are not billing Medicaid for these services, that could be a little more flexible. Next slide. All right, we will pause there and see what questions we have for Chapter 6. Again, feel free to come off mute, raise your hand, or drop anything into the chat.
Hi, Victoria. It's Tanya Wheeler.
Hi, Tanya.
Hey, so I know I've asked this question before. I want to be really, really clear here. So an RCO that is not an RSSO would be required to follow these rules. Is that correct?
That is not the case. So okay. An RCO that is choosing to operate as always as an RCO is not required to follow these regulations. Now, if an RCO, there's a very specific example that's coming to mind. If an RCO is contracting with a comprehensive safety net provider to provide these services, then that would be following these regulations. But an RCO that's operating independently, is not an RSSO, would not be subject to the regulations. Does that help?
Even if they're contracted with an MSO and so on?
At this point, my understanding would be no. This is really specifically built as the like a regulatory endorsement on that specific approval or license. So my understanding would be no.
Okay. I may keep asking this question just to make sure that we keep this going. It's a little bit confusing, you know, as we talk about the treatment agencies or the comprehensive organizations that are going to provide peer support services. I get that. But I'm trying to just make sure that we're all clear where the RCOs fit into this, or is it not inclusive of RCOs at all?
No, I'm glad you are bringing this up, Tanya. I'm sure if you have this question, then a lot of others have this question. So please keep bringing it. At this point, RCOs are not fitting into this structure unless they are being contracted as part of a safety net provider. So appreciate that question. I see a question about how are we expected to document the supervision requirements? That's an excellent question, Jessica. And I am reviewing the regulations right now. The intention that there is a documentation of that supervision. I'm seeing that might need, so the intention is there. We've gone through some revision processes and it looks like that does need to be added here. The idea is that it would be the same language that's in the RSSO license, that we do have a documentation of that ongoing supervision from either the supervisor or peer support professional. So appreciate you bringing that up. That expectation would be similar to the RSSO license. I see the question about an RSSO will still have to have a licensed clinician. So at this point, yes, the RSSO license is not undergoing revision at this time. And there were requirements initially baked in there because of the statutory requirement of that supervision, which comes from billing requirements. However, I say that, and when we get to the point where we are revising the RSSO license regulations, I think our intention is to move to more of this flexible structure, like in chapter 6 here. And so again, wanting to be more flexible on this licensing side, and then really having those specific billing requirements to HCPF live over in that billing world. So the answer for right now is yes. And I think our intention in the future is to move forward with more of that flexibility around supervision structure. And that all that to say, the RSSO regulations currently don't preclude others from providing supervision, but it does specifically name that a licensed clinician provides that supervision in addition to, or is the sole source of supervision. And I see the question, so as an RSSO, we could have a licensed clinician supervising the peer supervisor who supervises the, that feels like a riddle sentence in a great question. So I think I will need to take a closer look at the current RSSO regulations to really make sure I've got a correct interpretation there. I might need to take that back and just do a really close read as far as that. I will say also the big RSSO piece is that it also kind of has to tie in with Medicaid billing requirements. So even if something is a little more flexible on our side, there may be some differences there. But I appreciate that question, and I'll definitely do, hadn't reread the RSSO regulations in preparation for today, but I can absolutely do that to do a closer read. And thank you for that follow-up. I can definitely take a read there and follow up with you, and also get you connected with Jody if you're not already, our RSSO licensing manager. And then I see the question, can an RSSO contract with a licensed clinician, or does it need to be hired within the RSSO? So RSSOs can contract with the clinician. That does not need to be an employee of the RSSO. There is definitely flexibility there. It can be a contracted clinician. Awesome. Love seeing that feedback about Jody. appreciate that. And yes, absolutely. I will take a closer read and get with Jody, and we can get that question about that supervision and the layers of it answered for you. So appreciate that. And we can definitely give you Jody's email. And I'll give him a heads up that we shared that, so that he's not surprised with how popular he is all of a sudden. All right, I can work on getting that. Any other questions or feedback on chapter 6? Great. I want to say, we received so much engagement about chapter 6, and really just appreciate, I know some of the people on this call were part of that, and really appreciate all the hard work you did to help us get this chapter to where it is. And we want to use this as a model for our RSSO regulations moving forward when we're at the point to do that. So I will work on getting Jody's email, and I will also pass it over to, I think, Mel, who's going to kick us off in chapter 7.
We actually tricked you there. I'm going to jump in.
Keeping me on my toes.
Keep me on your toes. And actually, we got Jody's emails taken care of, so that should be in the chat at this point. So I'm going to go ahead and kick us off with chapter 7, and then hand it over to Mel to talk about most of the chapters. I'm mostly present for withdrawal management related elements. So chapter 7 is our behavioral health outpatient and high intensity outpatient services. For those of you that have been part of this process, in the winter, we had these separated into 2 different chapters, or technically 3 when you look at withdrawal management, how we had it. Received a lot of really helpful feedback about that potentially being a barrier unintentionally to services and making it more difficult. So what we have done is moved all of that together into one real outpatient services chapter that will hopefully make things a little bit simpler for the providers as well as the clients to receive the services that they need. So this chapter is going to span the continuum of care, beginning at early intervention services, our new ASAM level 0.5, all the way to level 2 withdrawal management. And we'll talk through each of those levels in a little bit more depth here. So as with all of these, we're going to start with our person-centered summary. There's a lot of words on the screen, and it's really little font, so I probably won't read every single one. But again, these person-centered summaries are available both in English and in Spanish on our BHA website if you're interested in looking at these separately. So having access to a range of behavioral health services is important for your well-being. This particular chapter sets the foundation for outpatient behavioral health services, from brief education all the way through managing of withdrawal management services. This all occurs while you remain in the community. Early intervention includes behavioral health education, screening and referrals. General outpatient services provides standard level of community behavioral health services up to 8 hours a week. Intensive outpatient programs provide more treatment during the week, at least 9 hours. And then partial hospitalization is available for more time in treatment and medical assistance, which may include medication management until you're at a place where you can move to general outpatient treatment safely. And then reducing or stopping drug and alcohol use is challenging. Outpatient withdrawal management services can help with that. This encourages medical and behavioral health professionals to safely monitor your symptoms of withdrawal while you remain in the community. All of these levels have requirements and expectations of practice to ensure you receive the best services. So as mentioned, kind of previewed on the header slide here for this section, this all is incorporated to really reflect a continuum of care, which was a significant bit of feedback that we received here. All of these voluntary service offerings are contained within this chapter. And withdrawal management is going to live where it would live in that continuum of care. So withdrawal management at an ASAM level 1 will live at the end of the level 1 services. Withdrawal management at an ASAM level of 2 will live at the end of level 2 services. You'll also see that we moved minor in possession, or MIP, to this particular chapter. It sits somewhere right in the middle of it. And one of the other real significant efforts that we made in this update was to make sure that the chapter formatting was really cohesive for more easy utilization of the chapters. So as an example of that, when looking at each of the sections, I believe with the exception of minor in possession, because that one's a little bit different, but all of them will have the same structure. For example, documentation and timeliness is going to be the chapter number, so 7.x.4, right? So 7.2.4 or 7.6.4, so that you can consistently find the information that you need going from section to section. And then
Mariana.
Oh, yes.
I'm sorry to interrupt you, Mariana. There's a chat from Lori saying she's having a hard time understanding. I don't know if maybe your computer is angled away from where you're looking, and so the microphone has a hard time picking up your voice. That'd be my only thought.
Oh, no. Okay, let me try something real quick. 1 second.
Our interpreter is saying the same thing as well. Oh, I think I scared Mariana and she just left.
Can you hear me better?
That's much better.
Okay. And Lori,
Thank you.
thank you for bringing this up. This happened last time. Mel, when you had some interference, that was me trying to get ahead of it. I put my headphones in, and the minute I did, you said I heard interference. So I stopped. My apologies. Hopefully, do I need to go back at all, or do we continue and then just make sure that we're going to cover all of that information in more detailed? Is that okay to just keep going, and then if there are questions, we'll come back to it? Does that make sense?
Well, actually, let me check in with Lori and see,
Okay.
was there a particular question, Lori, that you had that we should go back over?
No, I don't feel like you need to go back over it because I was
Okay.
reading, but it was just, I couldn't do the audio and read at the same time, so.
Thank you, Lori.
Yeah.
Yes. Okay, these will stay plugged in from now on. Okay, this is the last slide from me with my audio issues for a moment at least. So you will notice that there's a number of new definitions that are added to Chapter 7. One of them is follow-up services, and these are services that include interactions after the initial early intervention session that are intended to reassess the individual's behavioral health status. I realize I'm talking faster now that I know I can be heard, so I will slow down. These can help promote or sustain reduction in symptomology and risk factors for behavioral health disorder, as defined by the DSM-5 TR, and assess the individual's need for additional referrals. Get my chat back up here so I can see. Pharmacotherapy is another definition that was added to Chapter 7. And this is the treatment by an authorized practitioner of an individual's behavioral health conditions by using pharmaceutical products as medication. And then prosocial, which is a very important concept, has been introduced as a definition to this chapter. And my screen is covering it, means relating to or denoting behavior which is positive, helpful, and intended to promote social acceptance and friendship. I need to move my screen apparently as well. I think that's it for me and my technical issues. I will hand it over to Mel and be back in a few slides.
Thank you so much, Mariana. So let's chat about the first sub-endorsement that is listed in this Chapter 7, and that is a new one. It is Early Intervention Services, which includes ASAM level 0.5. Now, we added this so that we can better align ourselves with ASAM and make sure that we're covering all of the different levels of service offerings. This is for specifically individuals at risk of developing a behavioral health disorder and assessed as not appropriate for higher levels of care, or individuals that are currently diagnosed but stabilized and receiving screening, brief intervention therapy, referral to treatment, and/or education-only services are being provided. This may be provided in any setting, including telehealth, in accordance with Part 2.11.b, and the personnel must match levels of appropriateness for setting and screening, as again outlined in Chapter 2. Supervisor consultation must be available for personnel within 24 hours for psychiatric and medical concerns and within 1 hour for crisis or emergency situations. Next slide, please. The service provisions for early intervention services is that the duration will vary depending on the individual need and the type of service. We left this broad with the understanding that we could have an individual that has the screening happen and then they do 2 additional sessions after that, or has screening, does 3 sessions, then there's a break and then they come back for more sessions, or they may be mandated into some form of education-only services. So this is based again on screening information or regulatory assessment of education requirements from referral source for education only. The services overall can include brief individual, group, or family counseling, as well as those regulated education-only groups, such as DUI or DWAI or MIP services. Now, all of these may also include follow-up services. Next slide, please. The documentation for early intervention is pretty brief because we understand that there may not be a whole lot of sessions happening for this service. There is screening, and that shall be completed in compliance with that Chapter 2, 2.12.1, and that screening needs to be completed within 48 hours of that initial session. Then early intervention services are exempt from further assessment and service plan expectations because it's not appropriate for the service offering. The only exception to that is if the individual moves up in the continuum of care to outpatient or IOP, what may be found as more appropriate level of care for them. And those assessments and service plan requirements will then need to be completed. The emphasis overall on documentation for early intervention services is on the details around the referrals that may be provided to the individual. And progress notes are completed at a minimum frequency of only 1 note per session. Next slide. The next sub-endorsement in this chapter is outpatient services, or that ASAM level 1 is included in this sub-endorsement. Now, the regulations for outpatient services are adapted from CDPHE outpatient rules of 6 CCR 1011-1, 3.2, and current SUD outpatient rules of 2 CCR 502-1, section 21.210.6. Now, these are intended for individuals who are assessed as not appropriate for more intensive levels of care and may also be used as step down from higher levels of care. This may be delivered via in-person, audiovisual telehealth, or audio-only telehealth format in accordance with Part 2.11.b of these rules. And treatment groups must not exceed 12 individuals receiving services. Now that does not include facilitators or co-facilitators. So it's only 12 individuals that are receiving that treatment. Next slide. The personnel section has shifted in that we have removed that 50% candidate to licensed personnel language that you may have seen in earlier drafts. And we've added the clinical supervision section in Part 2.6.1. Now, the requirements or the percentage requirements for certified addiction technicians or CATs, and also for counselor in training or interns of 25% does still remain in the personnel sections for outpatient levels of care. Outpatient services may include also peer recovery support services. Agencies providing outpatient services must ensure treatment personnel have supervision consultation, again within that 24 hours to discuss psychiatric or medical concerns, or within 1 hour for crisis and emergency situations. Now, overall, outpatient services are conducted in regularly scheduled sessions of no more than 8 treatment contact hours per week for adults, and no more than 5 treatment contact hours per week for kiddos. Contact hours does not include pro-social activities, and we did receive some feedback to make sure that that was included in the rule draft. If referrals are needed, they will be provided in collaboration with the individual. We want it to be a collaborative effort of where that individual goes to receive different services that they may need. Next slide. Documentation and timeliness, everybody's favorite thing. So the how for general completion of documents is in parts 2.12 and 2.13. And the when to complete is found in the sub-endorsement. And you'll see that for all the various levels of sub-endorsements in Chapter 7. So the completion timelines are found in 7.3.4 for outpatient services. Screening is completed upon entrance into services. That initial assessment is completed within 10 calendar days from the first session, unless there's an urgent need identified in screening, and then that initial assessment is completed within 1 calendar day. The service plan is completed within 14 calendar days after the completion of the initial assessment. And then updates happen at a regular frequency at a time of individual's level of care or functioning changes, or a minimum of every 6 months. The comprehensive assessment is completed within 60 calendar days from the first date of services. Now, this is something that's different from when we first did stakeholdering for proposed rules in December and January. And based off of stakeholder feedback, we changed that timeline to 60 days for the comprehensive assessment to give folks more time to develop rapport and more time to gather that more in-depth information in working with the individual. Progress notes are completed at a minimum frequency of 1 note per session. Next slide. And I will hand it back over to Mariana. Oh, no, sorry, MIP. See, I wasn't reading my screen. So 7.4 talks about minor in possession. Now, this was moved specific to this outpatient services chapter because it wasn't appropriately aligned within living in where it was in current rule right now. And we wanted to make sure that it was moved to where it more appropriately fit. This is an optional sub-endorsement offering. So if you are an agency, be it a BHA or a safety net, you do not have to provide this MIP service. It is solely optional. If providing MIP services to minors under the age of 18, though, you do need to also receive the children and family endorsement. Now, we do have language in here about making sure that groups are divided appropriately. So ages 17 to 20 are in one group level, and under the age of 16 are in another group level. And they must conduct ongoing assessment of treatment needs while the minor is receiving services to ensure the needs are continuing to be met as they're receiving treatment. And now I will hand it over to Mariana to talk to y'all about level 1 withdrawal management.
Thank you very much. That would have been very fun. We'd all be keeping each other on our toes here. So I appreciate that. So I'm going to cover level 1 withdrawal management. So this is really exciting because this is a new level of care to the state of Colorado. Not new to the ASAM criteria, but this is the first time that we are looking to put a formal regulatory structure forward for this level of care. So very, very exciting. Level 1 withdrawal management is intended to complement individualized treatment. So we made sure to put language in there to really emphasize that it should not hinder the receiving of concurrent behavioral health services. This is meant to give individuals the best possible chance of recovery and helping to manage the withdrawal symptoms at the same time that they begin their journey into treatment or whatever service they need is what this is intended to be. The requirements for this level 1 withdrawal management service are directly adapted from the 3rd edition of ASAM criteria. And as briefly mentioned, when my audio was a little bit off, this is positioned in the continuum of care to become the new ASAM 1.7 once the 4th edition of ASAM does come out. So looking at some service provisions and documentation for level 1 withdrawal management, this is an outpatient service, and this is a medically focused model. So when you look at these standards in this section of rule, you will see that we follow the medical model for documentation, service plans, progress tracking. All of that really is meant to fit within existing medical model documentation to make sure that it's not adding additional burden and will be accessible to medical providers to participate in this service. The personnel may include, but are not limited to, authorized practitioners as defined in Chapter 1. And there are standards around the agency continuing and or providing medication-assisted treatment to individuals and only removing medications for opioid use disorder at the individual's request or if it is deemed medically necessary. And that is it for the middle part here. And I'm sorry, are we going to do the questions at the end, or do we want to pause and do, since we're kind of in between outpatient to higher intensity? What makes sense?
I think maybe we pause for the couple of questions we've gotten now, just because this is a longer chapter, and then we can keep going. Does that work for Mariana and Mel?
That makes sense.
Great. So there's a question from Tanya. Will the social detox model be going away in Colorado? It appears level 1 will be medical and does not include social detox options. Can you talk a little bit more about current state for social detox and potential future state?
Sure. And so, Tanya, you're talking about an ASAM 3.2 level of care and what that might look like with the 4th edition of ASAM. This is a bit of a hot button right now. I think there's a lot of people looking forward and really concerned about what ASAM 4th edition might look like for Colorado. This is a discussion that we're having internally to figure out how best to get ahead of that and make sure we're strategic in how we're going to address that. Current state, what we're putting forward is not disrupting anything that currently exists with the 3.2 services. We are, and again, we don't have slides on that this week because that will live in Chapter 8, which is our residential and overnight services. So we'll talk a little bit more about that at the town hall next week. But for the purpose of right now, there is nothing that is happening that will impact the 3.2 withdrawal management level of care. And we have heard the feedback that there's a lot of concern about how the social detox model might be impacted, and we will have more information for you all as soon as possible. I'm kind of looking for Tom, but I can't see him on my screen, so I don't know if he has anything to add to that.
I might jump in real quick and just say that we are moving forward with current state, and we will be talking more about, if you're interested in this discussion around social detox and ASAM 3.2, we will be covering that in, I believe, next week's town hall in Chapter 8, which is we incorporated the withdrawal management levels into their corresponding level, whether outpatient or residential. So we'll be talking more about what that current state is next week. If anyone's interested, that's all I'd add.
Thank you for that. Absolutely, Tanya. And then I see it looks like Cindy continuing down that path. Thank you for moving withdrawal management into the chapter. Thank you for the suggestion. Can you speak to why there needs to be a policy for circumstances under which individuals must be discharged? So I believe if you're looking at what we have put forward for ASAM level 1 withdrawal management and 2 withdrawal management, there is some discharge criteria for consideration of when it would be appropriate for an individual to move potentially to a higher level of withdrawal management services, or lower if they're moving from a level 2 down to a level 1. This is something that we continued. So discharge criteria is something that is listed in ASAM as a helpful guide for when that might be appropriate. So that is part of the reason why we have that listed in there, is to make sure that we're as aligned with ASAM as possible. And I believe that our withdrawal management section, and I might toggle back and look when we move into the next section to be sure, but does have some guidance around when it's appropriate to discharge from higher levels of withdrawal management services. And so we followed that, that type of approach to make sure that everything was covered. Does that answer your question, Cindy, or is there something I'm missing in there?
Marian, I appreciate that. I think, can you hear me okay? I've been having mic issues. Yes, awesome. Okay. I'll go reread that with that in mind, then. It's that statement that says circumstances under which individuals must be discharged other than completing withdrawal management or leaving against personnel recommendations. I think about some of the pieces that happen with us when we have places that kind of push us into a discharge mode that can make things difficult. And so I was just really wanting to understand that. But with what you just said, I'll also go back and reread this, and I might still provide further comment, but that's the sort of lens by which I'm looking at that.
Thank you. That is super helpful. And I heard in there a must, right? When we see must, that definitely puts it into a different category. So I will do the same on my end, go back and look at it and read it from that lens and see if maybe softer language of a must versus may was not, I'll go back and look at it from that perspective. So thank you for that.
Thank you.
And then maybe back to Victoria for MC. I think there was a question. Oh, and it looks like Mel answered Trisha's question around minor in possession, 16 and under for minor in possession groups. Were there any other questions outstanding before we move along?
I did not see any. I think we're all caught up. We can keep on going.
Great, thanks everybody. Back into the exciting world of outpatient endorsement, let's talk about intensive outpatient programming, or IOP. This does include ASAM level 2.1, and this is found in part 7.6 of that chapter 7. The requirements for IOP services are adapted from 2 CCR 502-1, part 21.210.71 through 21.210.711. And this means a service provider for individuals that require more structured outpatient treatment experience than can be received in that standard outpatient services. The programming may be treatment for mental health, substance-related, and co-occurring disorders of moderate severity or are of a higher severity, but the individual is stabilized. This may be delivered in person or through telehealth, including audio-only telehealth, in accordance with that 2.11.b of these rules. And again, those treatment groups must not exceed 12 individuals receiving services. Next slide. Personnel requirements, you'll see this section is very similar to the outpatient section. We again took out that 50% portion that you may have seen earlier. This staff and the personnel must ensure treatment personnel have supervisor consultation available within 8 hours via in-person or telehealth to discuss psychiatric or medical concerns of the individuals, and again within 1 hour for crisis and/or emergency situations. Training provided for this service offering by the agency needs to be appropriate to the treatment type that includes understanding signs and symptoms of behavioral health and co-occurring disorders and the basics of psychopharmacology. The service provisions for IOP remain the same from what you may have seen in the current CCR 502-1 regulations. And that is that 9 to 19 contact hours in regularly scheduled sessions that follow a planned format is IOP for adults, and 6 to 19 is for youth. Services can include a variety of different things as long as it's appropriate for that assessed individual need. And that can include individual therapy, various forms of group therapy, medication-assisted treatment and/or education, and so on. Next slide. The documentation timelines are the exact same as you will see in the outpatient section. So I will not reread those to you. And again, if you need to see these completion timelines, that is found for IOP in 7.6.4. Next slide. The next sub-endorsement is Partial Hospitalization Program, or PHP, and this includes that ASAM level 2.5 services, and you'll find this in part 7.7. The rules for this section are combined from 2 CCR 502-1, part 21.210.72 through 21.210.721, and Centers for Medicaid and Medicare Services, or CMS, PHP psychiatric guidelines of CMS L34196. And this means a service provided for individuals that require daily monitoring or management while providing clinical structure in an outpatient setting to treat mental health, substance use, or co-occurring needs, in addition to providing direct access to medical, psychiatric, and laboratory services. This again can be provided in person or via telehealth in accordance with that 2.11.b, and treatment groups again shall not exceed 12 individuals receiving services. Next slide. The personnel requirements are again the same. You will see that agencies must provide supervisor consultation within 8 hours via in-person or telehealth, and again within 2 calendar days in-person or telehealth when warranted, for those psychiatric or medical concerns. Being that this is the highest level of outpatient services provision, we want to make sure that those personnel are getting all of the supervision consultation that they may need for these individuals. And again, that consultation is available within 1 hour for crisis or emergency situations. Training again provided is appropriate to the treatment type. That includes understanding those signs and symptoms of behavioral health and co-occurring disorders and the basics of psychopharmacology. And then personnel providing medical services, we want to make sure that they have completed and maintained any medical training that's required for their licensing entity and to work within that behavioral health focused services. Next slide. The service provisions for PHP. Now, this is the only area that you will see for outpatient services where there is still a split between mental health and substance use disorder services. The reason being that in combining these two, the regulations are different. And so for this first step towards moving towards behavioral health instead of that difference between mental health and substance use, we're going to keep things current state while combining them in this chapter. And then in a future revision, we would like to move closer to parity in terms of service provisions. So right now, for mental health only PHP services, we're aligning with those CMS guidelines for that psychiatric provision. So services provided at a minimum of 20 or more hours a week. And within that 20 hours, that includes a minimum of 3 hours per day over the course of a minimum of 4 days per week. And that frequency and intensity is modified to assess individual needs. For substance use disorder and co-occurring PHP services, it's just a minimum frequency of 20 hours of regularly scheduled treatment contact per week. You'll see there that the SUD requirements do not have that minimum of 3, minimum of 4 that is found in that CMS language. So that's why there's continuing to be a difference with service provisions for PHP. Otherwise, the service offerings can again be broad as long as you're meeting that assessed individual need, and that can include individual therapy, play therapy, education, occupational groups, peer professional support services, just as long as you're again aligning with that assessed individual need. Next slide. Documentation and timeliness. For everything between screening and comprehensive assessment is the exact same as you have seen for outpatient and IOP. The only difference is, again, aligning with those CMS guidelines and with current state rules for PHB, is that the progress notes need to be completed at a minimum frequency of 1 note per session and 1 progress note per week. Next slide. All right, I will hand it back over to Mariana to talk to y'all about level 2 withdrawal management.
Awesome. Thank you, Mel. Okay, so here is our next new level of care that we are adding in. Again, not new to the ASAM, but this is new to the state of Colorado, so very exciting. This is ambulatory withdrawal management with extended on-site monitoring. Same concept as before, as we discussed. The rules that are written for this level of care are really meant to complement that individualized treatment and make sure that the individual, whatever other services might be helpful in their recovery, that participating in level 2 withdrawal management does not in any way hinder their participation in other behavioral health services. The standards for this level of care are adapted directly from the 3rd edition of the ASAM criteria. And again, this one is positioned to be level 2.7 in future state when the ASAM 4th edition comes out. Let's see here. So looking at level 2 withdrawal management service provisions and documentation. This again is an outpatient service, but this one has daily monitoring of symptoms and progress. So this is again medically focused, reads very similarly to the ASAM level 1 service, where it relies on the authorized practitioners and nurses that are providing the service to document within the service plan, progress tracking, any type of serial assessments that they do on a daily basis to identify how the individual is progressing. And it also allows for agency networking to meet the individual's needs. So this is a scenario where the provider might be a primarily medical provider that doesn't necessarily provide behavioral health services. So we want to make sure that we're encouraging a partnership with a behavioral health entity of some sort so that they can ensure that the individual's behavioral health needs are met in addition to the medical service that they're providing on the withdrawal management side. And then similar concept with the medication-assisted treatment, and in particular, the medications for opioid use disorder. There are standards in here to make sure that that medication is not stopped unless it is medically appropriate and something that the individual receiving services wishes to have occur. I do want to pause real quick while I was off camera there for a second. I looked at my handy dandy 3rd edition of ASAM to look at your questions, Cindy. And I do think that with your feedback around looking at the must versus some softer language will fit with what we're seeing in there. So thank you for providing that. We'll make sure to get that noted, as well as your note on adding the or in there. That is very helpful. And I have one shameless plug on a withdrawal management specific event that's going to be occurring tomorrow. So for those of you, some of you might have participated in our withdrawal management session last week. And we had a pretty robust discussion around what Tanya brought up earlier, concerns about 4th edition ASAM and where that's going to go. What does that mean for 3.2 withdrawal management? And we didn't get the chance to really look at current state. Here are the rules that we're putting forward because there were so many concerns around that future state. So what we did was take the opportunity to set up a second event for tomorrow. I'm going to try to put this in the chat and hope that it comes across okay. If that didn't work, Mel or somebody, would you mind getting the registration link? I just copied it directly from the calendar. That did not work. But this is going to be devoted specifically for 1 hour of feedback led by the community, by you as stakeholders, of what concerns you have about currently proposed withdrawal management rules. So level 1 withdrawal management, level 2, level 3.2 and level 3.7. And we're going to keep it very tight current state to make sure that all of the concerns that exist right now, we have the chance to address and receive feedback on. knowing that there is a huge concern around the 4th edition ASAM and the impacts that it might have on withdrawal management. Again, this is something that we are absolutely aware of. We are bringing up to the leadership level to figure out a plan, and we'll bring that back to you as stakeholders as soon as possible. That has not been lost on us. With that, any questions? I will look to Victoria to facilitate some questions here.
So I see a question in the chat. Have any of the tentative rules been added to ladders in the policy and procedure section? For example, currently ladders includes 21.210.1.b regarding agency staff qualifications, that 50% licensed staff, but I don't see that standard in the current standards. That is a great question. And we didn't talk timeline today, so omitted that piece of information that's pretty critical. So our current regulations, including that specific reference that you have, are in effect until these new rules come into effect, and even for a period of time after, until the agency is transitioning to these new regulations under BHA. So because these regulations are still in draft mode and we are actively receiving stakeholder feedback, these are not in effect yet. So that 50% ratio will be in effect until we have adopted these new regulations and the agency is coming under those new regulations. So we are expecting that these would be adopted effective January 1st of 2024. Ladders will not reflect any of the new regulations until they are effective and approved by the State Board of Human Services. And then the new regulations will apply once an agency is applying for that license. That's a good question. So these things that we're talking about today, this is not current state, currently in effect. This is all proposed regulation that we will be taking to our State Board of Human Services for approval, hopeful approval this fall, and then effective January.
Hey, Victoria, can you hear me?
Yes, I can.
Okay, so I'm the one who asked that question, and the reason I asked is because when I look at the copy of the current standards that I have, it's not in there either. And it wasn't in ladders last fall when I submitted updates for our applications, but it's in there now. So there's been a number of new things that have shown up in ladders that weren't there last fall. And so maybe I missed an update to the standards, but I was just trying to figure out, we're trying to do an update to a license now. And it seems like every time I go into ladders, there's new standards that I have that weren't there the last time I put responses in, but they are now. So I'm just trying to figure out if there's changes being actively made in ladders.
Then that question makes total sense. Thank you for providing that additional detail. I'll say a little bit, and then I see Mariana came off of mute as well. So that is not a new standard as far as what's in our regulations. However, my understanding is there's been a lot of work done to ladders. We had some issues with policies and procedures showing up under the wrong license types and things like that. So there has been an effort to clean that up and make sure that those policies and procedures are applying to the right providers. So I suspect that might be what's going on there, and we'll also pass to Mariana if you have any additional insight.
Yes, I will give this a try. So I'm just trying another screen share. I hope this works. You should be looking at our rule volume. Can people see that?
Yes.
I did it right. Okay, awesome. So this is our current rule volume as of, oh man, I'll have to go back to look at the effective date on this one, but this is the most recent one that should have populated what you saw in ladders. And Victoria's absolutely right. There's been some difficulties with getting things populated, and it has caused a little bit of heartache at times, or heartburn, I guess I should say. But the 50% rule in particular, where it lives right now, I'll just show you, it's the 21.210.1 agency staff section. We're going to scroll down, and this is where the current counselor in training and 25%, as we talked about, the interns and counselor in training, that will stay at 25%. but the existing 50% rule is specific to point E of this section around treatment staff. If you scroll down here, this is where it lives. Candidate staff receiving supervision shall not make up more than 50% of an agency's treatment staff. So that's where it lives in our current rule volume. And I can also, I can pull up the Secretary of State website to show if that's helpful to see how to make sure that you have the most recent version of the rules, because we did have a lot of changes over the past few years. So if you downloaded one, there is a chance that it is out of date.
Oh, and I think, thanks so much. I think that
Yeah.
I was just, it said it was 1.b, and so I was looking for that specific. And the language, I just couldn't find the actual language in the standard.
Oh, I
The same way
gotcha.
it's written in ladders, so
Yep.
I just did a search for the language, couldn't find it. So I think the language maybe is just a little different, or it's the wrong letter or something.
It probably had the
makes
wrong
sense.
letter. One kind of trick that I use quite a bit when you're in there is if you do Control F, and then if you have a keyword to search for, that can make life a lot easier. So in that case, you could search for like %, and it should jump to any place in the rule volume that has a % listed in it. So that's a trick that I use quite a bit to make sure that I'm keeping track of what lives where.
All right, perfect. Thank you, guys.
You're welcome.
All right, the floor is still open for any questions or feedback. We're doing great on time today. We've got still half an hour left. If folks have any additional questions or comments.
Can I do one more shameless plug? So what we just did right there with sharing the screen and looking to find something that that you had a question about is what we've been utilizing our office hours times for. And so we had a good bit of turnout the first week where we did office hours. So we've went ahead and scheduled an hour every week from this point through the end of stakeholdering, where one or multiple of the safety net staff will be present on a call, and you can literally hop in, ask your question, provide your feedback, get it answered, and hop back out, or choose to stay the whole time if you would like. We have not been recording the office hours because they're not intended to be public facing in any way. So that is one thing to keep in mind, but we are making sure to identify which other events will be public facing and recorded so that you can access those in the future if you're not able to attend. And then Erin, I see your question about the recording. Could you please add timestamps for the different chapters? That is a brilliant suggestion. I will bring that back to our communications team and see if they can do that before they upload it to YouTube. Thank you for that.
All right, not seeing any hands or any additional questions. I'll start giving a few more plugs for upcoming events. And then if you're still typing a question or have something in mind, feel free to send that in, but I'll kind of start giving our little spiel. So we have our in-person meeting this in Canyon City this Friday. And we also have an in-person meeting on Tuesday in Durango. So those are both going to be listening sessions. So unlike this session where we did a lot of talking and walking through content, we will be pausing to ask questions and really focus on listening. Mariana has dropped registration for upcoming in-person sessions. So this week, Canyon City. Next week, Durango. The following week, I believe, is Grand Junction, and then Pueblo. So we've got a few more coming up. We also have our town halls to walk through the remainder of our rules. That would be chapters 8 through 15. And then we have, again, some of those additional opportunities mentioned about our withdrawal management specific providers. We have an SUD provider specific meeting tomorrow. And we also have our lived experience sessions. We've got 3 more of those, one in English, one in ASL, that one's tomorrow, and we have our Spanish speaking session coming up as well. You can find all of the details about that on our laws and rules webpage on the calendar there. And so we look forward to seeing you at any and all future events. Not seeing any additional questions or comments. Anyone else from the BHA team have an announcement or anything for wrapping up?
No, just thank you so much, everybody, for your time today. Appreciate y'all.
Great, thank you. And a special thank you to our interpreters who had to interpret a lot of citations and technical terms. So thanks everyone who came to be here with us today, spend your lunch break with us, and we look forward to seeing you in additional meetings. And this recording will be up on the YouTube as soon as we can get that downloaded. So thank you.